Hello and welcome to my ophthalm teacher. We have discussed about the cataract surgery in the part 1 and 2 of this lecture series. So finally, we talk about complications of cataract surgery today. So they are broadly divided into two types, intraoperative and postoperative. Intraoperative can be anesthesia related or surgery related, and postoperative can be early or late complications. So let us talk about the intraoperative complications. First, anesthesia related. Now, the only anesthesia related complications that happen are from the peribulbar or the retrovulvar block. And in setups where topical anesthesia is used, these complications are not seen. So, the first complication related to peribulbar or retrovulvar block is a retrovulvar hemorrhage. This happens when there is inadvertent or vital vessel rupture leading to bleeding into the orbit. Right? You see, this is a retrovulvar block being given. So it is more common with a retrovulvar block rather than perivulvar blocks. That's why it is necessary that when we insert the needle, once the needle is completely inside, we always aspirate to look if there is any blood, which is indicative of a orbital vessel rupture. So retrovulvar hemorrhage, this is how it presents. There is bleeding behind the orbit, obviously, so there will be proptosis, there will be periocular redness with tense orbit, right? Because the bleeding happens in this region, right? So it tends to push the eyeball forward. Then globe perforation. Now, as you can see, we are going very close to the sclera, right? So for beginners, whenever the perivulvar block is administered, for beginners, it is recommended that after inserting the needle, one asks the patient to move the eyeball from side to side to ensure that the sclera is not engaged. If it is, remove the needle and place it in another position. So else globe perforation can happen if it perforates the globe, that is the sclera. It is more common in high myopes and it would lead to an intraoperative low IOP and create problems for the operating surgeon. Injury to the optic nerve can happen. Now, this is very rare, and if only if it penetrates the optic nerve, right? So there is a long way behind, right? So this is a rare complication. Theoretically possible, yes, it may result in a secondary central retinal artery or vein occlusion because they are closely related to the optic nerve, and ultimately there will be optic atrophy, right? So you see this pale white disc, that is optic atrophy, and anaphylactic shock following injection into the optic nerve or its sheaths. Next, we come to surgery related intraoperative complications. So there can be a subconjunctival hemorrhage, more commonly seen with SICS, in which we do a peritomy, right? So some blood vessel may bleed excessively and lead to accumulation of blood below the conjunctiva. It looks like this. It's a bright red, sharply delineated area surrounded by a normal appearing conjunctiva. What else can happen? Iridodialysis. See, this is the iridodialysis in which this part, there is no iris here, right? So this can be because of inadvertent pulling of the iris during any surgical manipulation. For example, delivery of a very big hard nucleus, such as seen in brown cataracts. So this kind of a thing can happen, and it is detachment of the iris root from the ciliary body. And this is your typical D-shaped pupil seen in iridodialysis. Hyphema, the bleed can happen from the iris vessels, it can happen from the conjunctival vessels and enter the anterior chamber. So whatever the source is, hyphema is when it collects at the bottom, right? So blood in the anterior chamber. Hypopion is pus in the anterior chamber. Then posterior capsular tear or rupture. Now look at this. The IOL is in place. This is the margin of the capsulotomy, right? A CCC has been done, and this is the margin of the CCE on the anterior capsule. What is this structure that you see here? That is the dehiscence in the posterior capsule. The lens is in between the two. So this is a PCR, which may have happened intraoperative, right? Next, we have subluxation or dislocation of the lens. Subluxation is when it is still in the patellar fossa, right? It is either, up or move down, but it is still within the patellar fossa. Dislocated is when it enters the PC, that is, it falls into the vitreous or it falls anteriorly into the anterior chain. So this is probably a subluxated or a posteriorly dislocated IOL. You see the gap here, right? So that is a subluxated or dislocated IOL. It can happen intraoperatively. It can also happen postoperatively. Zonular dialysis. By zonular dialysis means we mean tearing of the ciliary zonules. So you see a phaco is being performed over here, and look at that space. So basically, the zonules have somehow been pulled, right? So they rupture and the lens shifts. Now, zonules are the support of the lens, they are the circumferential support, right? So, pulling on the zonules would lead to an subluxation. So, that's one cause of intraoperative subluxation, pulling too much on the zonules, or pre existing zonular weakness as seen in pseudoexfoliation syndrome. Then there can be descemet tear and endothelial damage. Look at this picture over here. You see this white striate, sort of design on the cornea. That is corneal edema along with the folds in the descemet membrane. These two lines are the folds in the descemet membrane. Expulsive hemorrhage. It's a rare type of choroidal hemorrhage wherein there is extrusion of the intraocular contents through the surgical wound. You see there is extrusion of the iris here, and subsequently vision is lost. Basically, everything is expelled through the wound over here. Vitreous prolapse. Vitreous prolapse would happen if there is an accidental tear of the posterior lens capsule. What happens is, for example, here, you see, this is a diagrammatic representation of the cortex being aspirated. Okay, this is the anterior capsule opening, and this is the intact PC. Now, sometimes this probe may catch hold of the PC over here and cause it to tear. If this tears, this anterior chamber and posterior chamber become continuous. So the vitreous starts to flow posterior to anterior, and it may be present in the anterior chamber over here. So this phenomena is known as vitreous prolapse. Moving on to the postoperative complications, the early postoperative complications. So striate keratopathy. This we had seen intraoperatively also. This can happen, corneal edema. And this is the same thing. These are on high magnification, you see that these are the descemet folds. So corneal stromal and epithelial edema due to endothelial damage, often seen in prolonged surgeries and very hard cataracts. Shallow anterior chamber. Why would the anterior chamber be shallow? Because of probably wound leak. There is a wound over here, it is in continuity, the aqueous is in continuity with the outside, as a result of which there is wound leak and shallowing of the AC, the IOP will fall. There can be pupillary block like this because of bowing of the peripheral iris, choroidal detachment, malignant glaucoma. So basically, this figure is trying to show that there is a sort of iris bombay formation over here because of back pressure from the vitreous, because of something, maybe because of, some choroidal hemorrhage or something. And the iris is blocking the anterior chamber angle, leading to shallow. That is one cause, pupillary block, right? And another cause, as I told you, is wound leak. Wound dehiscence, again, may lead to hypotonia. That's your corneal edema over there. Next, hyphema. Blood vessels in the base of the wound or possibly from the iris are usually the source of the blood. Okay, we discussed that. And this can happen intraoperatively or early postoperatively. Iris prolapse, again, both intraoperative and early post-op complication. You see, there is a wound over here. Probably a premature side coat has been made, maybe, and the iris has popped out of that wound. Post-operative uveitis. Now look at this diagram over here. You see that the inflammation is so severe that a pupillary membrane is formed. And these things, these brown dots on the surface of the lens are actually iris pigments. Here is, we have the retained lens matter, residual cortex in the anterior chamber. Okay. Here, maybe in a particular quadrant, the cortex is remaining and it is seen as a fluffy white structure in the early post-op period. Postoperative glaucoma, again, because of pupillary block, as explained, pupillary membrane, as we saw in the previous slide, and other causes like glaucoma, where vitreous blocks the pupil. Bacterial endophthalmitis, the most dreaded complication, the most dreaded by who? By surgeons. Thankfully, the rate is less than 1%. You see, the pupil is fixed, right? There is severe corneal edema, there is marked congestion, and there may or may not be a hypopure. Late postoperative complications. PCO is the most common late postoperative complication. It is basically the opacification of the posterior capsule because of migration of any remnant lens epithelial cells between the anterior and the posterior capsule, right? LECs. So you see, this is the Elschnig-Pearl variety of PCO. This one is the somewhat like a sovereign ring in which there is a ring-shaped formation of opacity. Okay, even the IOL is dislocated. It's not in its physiological position. Cystoid macular edema. This is a fundus fluorescein angiogram showing leakage at the fovea in a somewhat petaloid pattern. And this is an OCT of the same eye, the normal other eye versus the cyst-like spaces seen at the fovea over here, suggestive of cystoid macular edema. If the cystoid macular edema happens postoperatively, it is referred to as Irwin-Gass syndrome. And why does this happen? It happens because of inflammation and break in the inner blood-retinal barrier. Unpredictable as astigmatism, more commonly seen in conventional ECC and SICS. It is less common with the sophistication of the surgical procedures and a number of a number of techniques used to control astigmatism, such as limbal relaxing incisions, clear corneal incisions, and so on. Then persistent chronic uveitis, such as this one. IOL related complications like decentration, dislocation, um, to urge to humans. So there could be a mistake in the calculation of the IOL power. So wrong IOL power, obviously it would not lead to the expected visual outcome. Late onset endophthalmitis. We saw what endophthalmitis looks like. Retinal detachment. You see, this is the retinal detachment over here. This is the detached retina. And bullous keratopathy, pseudophakic or aphakic bullous keratopathy is basically because there is too much of endothelial damage that has happened during the surgery. So basically, this is the IOL over here, and look at the cornea. It looks like ground glass appearance because it is thick and edematous. So that's pseudophakic bullous keratopathy. So that's it about the complications, and thank you for watching. Please remember you can get complications as a long question, and you can get any any particular complication as an MCQ, Viva questions. It is important to read the complications of cataract surgery. So the presentation will be available on my YouTube handle, My Ophthalm Teacher. Thanks once again.